Thank you, respected chairpersons and delegates, for sharing your valuable knowledge with us.
Now, let us commence the symposium on the cardiovascular conundrum of diabetes with our respected panelists, Dr. Sameer Kubba sir, Dr. Dheeraj Garg sir, Dr. Vivek Kumar sir, Dr. P. Venkata Krishnan sir, and Dr. Paras Gangwal sir.
Begin our discussion on the cardiovascular conundrum in diabetes. As we already know that cardiovascular diseases are increased in patients who are having diabetes, and along with other risk factors like hypertension, dyslipidemia, the incidence of ASCVD, that is coronary artery disease, peripheral arterial diseases, and cerebrovascular disease, as well as heart failure, is increased in patients with diabetes. It has also been seen that occurrence of diabetes also increases the incidence of other risk factors in a person with a diabetes. So nowadays it is a multifactorial risk factor reduction which is required to prevent these adverse events. So now ADA recommends that a person with diabetes should follow lifestyle modification, dietary restrictions, blood pressure management, lipid control, glycemic control, and there should be drugs which should target our cardiovascular system and the kidneys. So we will now start our discussion, and I would like to ask Dr. Sameer sir to elaborate on the role of lifestyle modification and dietary modification in a person who is having diabetes, and how do they affect the atherosclerotic cardiovascular disease risk.
Thank you very much for that very important question, and I believe that the theme of today's conference is to make diabetes care accessible and affordable. So I think the most accessible and affordable therapy is diet and lifestyle modification. It's freely available to everybody, and no doubt we have drugs which have now come up for the management of diabetes, which produce significant weight loss, like the SGLT2 inhibitors, the GLP-1 analogs. And when I was doing my training, we hardly had any drugs beyond sulfonylureas and metformin, and then insulin. And all these drugs were either increasing weight, or they would actually lead to a weight neutral sort of a scenario with metformin. Having said that, the role of diet and lifestyle modification cannot be overemphasized. I think that is something which is more important than any other thing. And even the AHA recommends the essential 8 factors in the management of a routine human being for prevention of cardiovascular disease. And the first and foremost is diet, which must include fruits, vegetables, and exercise, which must actually be about 45 minutes a day. And if it's a vigorous exercise, then it could be a 75 minutes in a week. Moderate degree of exercise, about 2.5 hours a week. Even a small amount of weight loss can improve the insulin resistance. The traditional Indian thali, I would say, as far as diet is concerned, is one of the best ways to go about it. You would be surprised to know that Salim Yusuf, who actually looked at the Inter-Heart study and also the study on the role of fats, which was supposed to be a controversy, that fats at times may increase cardiovascular issues or sometimes they may not. So when he actually looked at this hypothesis and paradox and published it, so when he was talking to his grandmother, he said, "What new have you published? This is what we have been doing since you were born." So what I'm trying to say is that we have now a lot of packaged foods and a lot of food outside home, the kind of cooking oil which is used. Again, coming to the cooking oil, the non-tropical oils like olive or canola are the best. Even mustard oil in some scenario might be okay. So that's a topic in itself. But I believe the bottom line is there is extreme role of diet and lifestyle modification, and that is the most important thing. You may require drugs when you have, I would say, sugars in the very high range, or the HbA1c crossing 7.5, or patients presenting with diabetes complications. But diet and lifestyle modification are the Ramban of diabetes management.
Thank you, sir. So my next question will be about what should be the ideal blood pressure targets in a person with diabetes. There have been many trials, and there have been groups with intensive blood pressure reduction and standard blood pressure reductions. So what should we prefer when we are trying to treat hypertension in a diabetic person?
So that's a very important question, and it's always a matter of controversy. For so many years, different guidelines come and they recommend, and becomes very confusing for the treating physician in his clinic. So I'll make things very, very simple. The latest European Society of Hypertension guidelines now strongly recommend that don't go below 120. The SPRINT trial actually showed that aggressive blood pressure control could prevent cardiovascular complications, but the biggest problem with aggressive blood pressure control is patients become symptomatic with dizziness, fatigue, and then they come back to you, and then you try to stop these drugs, and then then they have these blood pressure fluctuations, and the BP variability is also a strong risk factor for cardiovascular events. So European guidelines, I say, are more in sync with the Indian guidelines. The definition of hypertension is very clear: BP of more than 140/90 on multiple occasions. The target is very clear: do not go below 120. And in elderly people who are, say, around 78 years of age or frail, maybe even up to 150 or so systolic blood pressure, you may just manage them with diet and lifestyle modification, and may not be very aggressive in giving them drugs because they can have postal hypotension and other things. So you have to take into account many factors. If a patient is young, if the patient is obese, if the patient can tolerate the drugs well and has high cardiovascular risk factors, you may try to achieve a blood pressure systolic around 120 and diastolic around 70. But most of the situations, I think 130 systolic, around 80 diastolic is the best. And what I do in my practice is, when I write the blood pressure targets in my patients, I say do the home blood pressure monitoring and try to maintain the blood pressure between 120/70 to 135/85. In most scenarios, it works.
Okay, sir. So, as you have said that the ideal targets will be 130/80 or 120/70. And some studies have shown that when the baseline blood pressure is more than 140/90, at that time initiation of antihypertensive therapies have their most effect. So what should be done for a patient who is in between this range, like between 130 to 140 and 80 to 90? So should we start antihypertensives or just wait for the BP to rise or something else?
Yeah, so again, that's a very practical question. I think this is the time to assess the associated risk factors. So suppose somebody is having no other risk factors. You may have a wait and watch policy in this patient. And let me tell you, we are discussing about blood pressure not only for the antihypertensive drug management. The guidelines say give them a diet and lifestyle modification for initial some time. Suppose somebody has a blood pressure of more than 150/90 is having symptoms, you have to initiate a drug. But in this kind of scenario which you are mentioning, I believe it's important to look at the associated risk factors. Somebody who has multiple risk factors, like he's a smoker, obese, diabetic, family history of coronary artery disease, family history of CKD. I mean, in such patients, maybe an aggressive blood pressure control is important. But if somebody who is not having these major risk factors, you can wait and watch. And it's difficult but not impossible. You call them up over and over again, maybe have a counselor with you who can actually call them up and look at their blood pressure targets. Nowadays we have online programs also wherein there are health coaches and counselors who can actually guide them. So then you can delay the initiation of antihypertensive therapy. Having said that, it's also important to know your patient very well. Some of the patients you know would actually listen to your advice and would be aggressive in taking care of their diet and lifestyles, and some of the patients you know will not be able to do. So in that case, it's important to initiate the drug therapy early, because they can have a stroke or an MI as their first presentation. And blood pressure variability is also very important. So maybe doing an ambulatory blood pressure once and a 24-hour ambulatory blood pressure once, or encouraging the use of home blood pressure monitoring is very important. I think this is something which we must take home today. Please, every patient or everybody in the house must have an automated blood pressure cuff instrument. That is the recommended instrument. Now there are no recommendations for mercury sphygmomanometers or anorite. I think it's the automated blood pressure instruments which are very important, must be available in everybody's home. The COVID pandemic has taught us that this can be easily measured, and they are very, very reliable. Patients come to us and they say, I don't think that is reliable. So I think you have to reiterate to them, it is very reliable. Maintain a chart of your blood pressure, and then they can become partners in their own healthcare management. So that becomes very, very important. Empowering the patient to monitor his blood pressure, a very, very simple strategy. And the latest guidelines, the ESH endorse that home blood pressure monitoring should be encouraged much, much more than an office blood pressure monitoring.
Thank you very much, sir. Now I will like to ask Dr. Parag a few questions. Sir, as Dr. Sameer has already mentioned that the cutoffs for blood pressure would be 130/80 or 120/70. So if a person has a low diastolic blood pressure to start with, but the systolic blood pressure is still high, so should a low diastolic blood pressure a deterrent to start or intensify antihypertensive therapy, as the most of the perfusion of heart occurs during diastole? So what should be the lower limit of diastolic blood pressure which we can achieve safely?
I think this is very, very important question. That while we are saying that we lower the blood pressure further, let's, based on the sprint trial, bring the systolic to 120. So there have been concerns that as we bring the systolic blood pressure lower, our diastolic is also going to go low. So that people started thinking, shall we really go that low with respect to the systolic blood pressure, compromising the diastolic blood pressure further? So there has been good amount of data and studies on that by various authors, and as a follow-up study of this Hopkins Institute has taken up this further with more than 11,000 patients who have followed for more than 21 years in the ERIC study. And they found that those who reduce their blood pressure to less than 70 versus those who reduce their blood pressure less than, diastolic blood pressure less than 60, they had more troponin I elevation as a part of the myocardial damage. They had more chances of ischemic event, and they had more chances of dying as compared to those in whom diastolic blood pressure was kept more than 80 or even hovering till 90. So it was found that should we really lower the systolic blood pressure with diastolic being compromised to less than 70? So most of the data says that till 70 it is okay. Less than 70 going till 60, the chances of increasing drop I elevation are 1.5 times. If you bring diastolic blood pressure less than 60, the drop I elevation chances would be twice. So that is how it goes with respect to diastolic blood pressure. Having said that, that as a isolated diastolic BP lowering, what we call as isolated diastolic hypotension, you started treating a hypertensive patient and now you have created a isolated diastolic hypotension. So this is one component with respect to only a diastolic blood pressure, keeping in mind. The other component is when you target the blood pressure as a wholesome value, you are looking for the systolic blood pressure, you are looking for a diastolic blood pressure, you are looking for a pulse pressure. So again, there is a lot of data which says that as long as you do not decrease the pulse pressure, you do not widen the pulse pressure much, you do not do harm. So how do you evaluate that? Suppose somebody you are targeting at 140 blood pressure. So what they say is 68 pulse pressure is the limit. You should not widen the pulse pressure by more than 68. So for ease you can remember maybe 70. So let's assume that whomsoever we treat, we should not do anything to widen the pulse pressure more than 70. So if somebody is 140 systolic blood pressure, minus 70, keep the diastolic towards 70. If somebody is 130 blood pressure, minus 70, keep the diastolic towards, with 70 difference, 130 minus 70 would make it 60, right? So the pulse pressure is also parallelly important. If you decrease the pulse pressure, you have more benefits. If you widen the pulse pressure, your benefits are lost. Then again, one more data that if you reduce the diastolic blood pressure less than 55 at any one point in time in patient management, your whole benefit of lowering the systolic blood pressure is all mitigated. So that's why is diastolic blood pressure important? Again, that is an important component because our myocardial supply happens during the diastole. So that is why it is very important to maintain that coronary epicardial flow, that we have to have a diastolic blood pressure which is reasonably well, preferably 70 and above. And we have to take care of the pulse pressure also.
So during the course of diabetes, many patients go on to develop autonomic neuropathy. It itself is a cardiovascular risk factor and it makes the patient to have labile blood pressures. So how to go about in such patients?
It's again a very important question that we say in our day-to-day life, and we see many diabetics who are having peripheral neuropathy. It is again said that those who are having peripheral neuropathy, 50% of them may have cardiac autonomic neuropathy, though we do not evaluate them well, but as per the available literature, that is how it happens. And Amitesh is sitting here. When I was a senior resident in GTB, Dr. Madhu gave me first case to evaluate. You do testing for autonomic neuropathy, whether this patient has autonomic neuropathy or not. So I have my connection with autonomic neuropathy since that timing. So when we are trying to manage these patients, there are 2 or 3 things in our mind which comes, that they have a component of orthostatic hypotension in the daytime. They have a component of systolic hypertension in the night time. So to prescribe them drug is very tricky. So suppose they are being managed for the night systolic hypertension. So first comes, what is the definition of that? In a patient of autonomic neuropathy, somebody who is having orthostatic hypotension in the day, how do you define the systolic hypertension in the night? So to define that, make them lie for 5 minutes in the bed. If you have their lying supine blood pressure more than 140/90, you, even in a case of orthostatic hypotension in the day, you will say that they are hypertensive in the night. So you have 2 things to manage in the night. One is the blood pressure, and the second is their pulse rate. Their pulse rate is higher. So you want to use an agent which lowers the blood pressure only for a small while. So maybe agents like, which are short-acting agents, there have been many studies on them. It may be clonidine, which works for a short while, short duration action, or it may be, they say, captopril. So keep the dosing and timing like that they do not overdo for the morning. And same is for the heart rate control. You may use a short-acting beta blocker and accordingly manage their heart rate also. So these are my takeaways about this.
Sir, there has been a recent concept of chronotherapy, that we have to harmonize the drug administration with the natural circadian rhythm of the body. So, as you have said, for autonomic neuropathy, I can understand that nighttime administration of short-acting antihypertensives is good. But is it effective in other cases also, those who have not developed autonomic neuropathy till now? So, what should be the ideal timing of antihypertensive, whether it should be given in morning or evening?
Again, there has been many studies and concepts evolving around whether we should give a antihypertensive drug in the day or in the night. So why these concepts are prevailing? Because one fact is very much certain across all the studies is that nocturnal lowering of the BP is related with better CV outcomes. What we say is the nocturnal dipping. If somebody is having a nocturnal dipping, likely that he will have less CV outcomes. So same as I was telling about the autonomic neuropathy. If somebody is not having a nocturnal dipping, that means he has a more likelihood of a cardiovascular events. So that is one aspect of seeing why do we want to decide whether to give a drug in the day or in the night. Then does giving a drug in the day versus night make nocturnal dipping more pronounced? So this is known as what we call as chronokinetics of the drug, right? So while we say that giving the drug in the night may lower the night BP slightly more than what it lowers in the day, has to do something with the chronokinetics and the circadian rhythm. So what is chronokinetics? Chronokinetics is when we lie down, our circulation is different, our gastric emptying, gastric acid secretion time is different, the vascular flow into the hepatic system is different. So drugs pharmacokinetics is changed because of this chronokinetics. Second component is circadian rhythm. We all know that as we get up in the morning, there is surge of adrenaline, catecholamine surge is happening. There is increased resistance in the vascular system, whether it is the peripheral vascular system or whether it is the coronary flow system. So there's increased resistance, there's increased platelet aggregation as we are happening to get up. So in the morning, we have a lot of factors which are influencing a bad cardiovascular outcome if our BP surge is happening. So that's why this concept of can giving a BP drug dose in the night make a difference. So there's a good Cochrane review on that, a recent one and the earlier one. So it was found that among 74, I think more than 70 studies, I think 72 studies, data they analyzed, they found that once you give a drug in the night, what do you achieve? You achieve a 4/2 BP reduction in the night as compared to when you give it in the day. So that means you create a nocturnal dipping by giving the dose in the night. But then there was a bias in this data analysis. They removed 23 studies, which was by one of the main contributors. Then if those 23 studies were removed, it was found that there is no difference. So there is some bias in this data, but maybe all said and done, if we can give a single drug in the night, it may help reducing your nighttime BP, and it may make a non-dipper a dipper with more CV benefits. Then again, a corollary to it, whatever you do has to fit in with your patient profile. If your patient has more compliance and more tolerability, lesser adverse effect, taking the drug in the day, you probably may continue with the day. Else, if patient drug is suiting in the night, it can be given in the night. Then there is another add-on to it. Now we have ambulatory BP monitoring, which can help you decide which therapy, which dose we can intersect with, at what point in time.
So we can. Yes.
Yeah.
Ambulatory blood pressure, which sir was mentioning, is very, very important. And I think each and every hypertensive once in lifetime must have an ambulatory blood pressure. It tells you about his own circadian rhythm. So it will individualize therapy to that patient. Having said that, giving drugs during the day is more practical, more important, the compliance is better. The latest trial, a time trial actually looked at this. We have trials like HIVET, which actually showed that giving in the evening may be better. Then Indians are sympathetically overactive, and the maximum amount of sympathetic overactivity in Indians is seen around 6 o'clock in the evening, so maybe giving beta blockers at that time. So there are so many varying data and conflicting data, and as Dr. Paras was exclusively mentioned about so many trials, so at times leads to confusion. So best thing is give a drug or a combination of drug in a single pill which has a 24-hour action, preferably in the morning, because that is the way in which the compliance can increase. Do not give your diuretics in the evening time. And then if the ambulatory blood pressure suggests you that the patient is a non-dipper or has nocturnal hypertension or things like that, you can individualize or titrate therapies according to his circadian rhythm.
Thank you, sir.
Just to add on to that, if you analyze those data actually, those studies, you just remember how much is the BP variation. So it is just 4 millimeter of systolic dipping in the night, 1.5 to 2 millimeter of diastolic dipping in the night, and 1/0.6 change in the day when you change the timing of the drugs. So you have to keep those things in mind. I think same thing can be achieved by a very good BP monitoring by the patient, and you being able to interpret that well, because one single reading at your clinic and you are trying to titrate your dose based on that single reading, as Samir has very rightly said, I think all patients have to visit us with a prior 5 days. When they are planning a visit to the physician, it should be made mandatory whether you monitor your, you are making visit for the sugar or making a visit for the blood pressure. You please make a chart of previous 5 to 7 days and then report to your physician. You go to US Embassy without your documentation, you will be returned back. A physician visit, you want to go to physician, just get into his chamber, doctor साहब low में आ गया types, and क्या आ गया भाई कुछ है BP sugar का chart है नहीं. It's a useless visit. The whole money is wasted. You can just translate the concept to the patient कि भाई ये दवाई है बड़ी हो तो ये वाली ले लेना घटी हो तो ये वाली लेना. You have not been able to individualize with all your expertise because patient has reached to you without any charts. So I think what we all should promote our patient, please book an appointment, start making a chart, make a chart of 3 to 5 days at least so that I can suggest you better.
That highlights the importance of monitoring the blood pressure even at home. Thank you, sir. My next question will be to Dr. Vivek, sir. Sir, what should be the ideal lipid targets in a person with diabetes?
See, all the patients of established ASCVD do not have same adverse CV events in the future. So for this, the Lipid Association of India has formulated a matter, or they have given some recommendations recently. So the patients who are having established ASCVD and diabetic patients, then if they are having one or less major adverse risk factor for the future, like smoking or if homozygous hyperhomocysteine, etc., then these patients are categorized as extreme category, and again in this category they are categorized as category A and category B. So in category A, the diabetic patient having ASCVD, one or less major adverse risk for the future without any end organ damage, then their target LDL is said to be around, they have recommended it to be less than 50, but in some optional cases, if we go with less than 30 also, it is also recommended as an optional target. So again, in category B, we go, the patient is diabetic, then patient is having established ASCVD, then if the risk factors are 2 or more, then again, if the patient is having end organ damage, then they are categorized as category B, extreme category B. So in this group, we have given a recommendation that the target LDL should be less than 30. So again, if some patient is already having a patient of CAD or established ASCVD, if even the targets of less than 50 are reached, then if the patient is again developing an acute CV event within a 12 months period, then the target LDL will be decreased to 30 LDL.
Yes, sir, so we know that we can use statins, ezetimibe, and PCSK9 inhibitors to achieve our LDL targets. There is a new molecule by the name bempedoic acid. So where does it fit in treatment of diabetic dyslipidemia?
So we have mainstay of treatment of hyperlipidemia till date was statins and some of the non-statin drugs also. So the newer drug bempedoic acid, basically it is a prodrug. So again, the mechanism of action is it is about 2 steps up from the HMG corelatase pathway of the cholesterol metabolism synthesis. So again, it acts by the inhibition of ATP citrate lyase enzyme. So this is, since it is a product, it becomes active in the liver after metabolization. So the active metabolite is not accumulated in the muscles. So the one of the main benefit of bempedoic acid is that it does not cause any muscle symptoms like statins. So it is beneficial in the patient who are having statin intolerance in the form of muscle symptoms. And again, bempedoic acid again can be used in the patient who are having maximum statins and non-statin drugs and still not able to reach their target LDL levels. So again, in this, another drug was PCSK9 inhibitors. They are a bit costly. So that's why the role of bempedoic acid is there. So in the clear study has done a series of trials in which it has shown that the bempedoic acid itself, as a monotherapy at the end of 12 weeks, about 25 to 30% reduction of the LDL is seen. And in combination with statins, it has given the additional benefit of around 15% reduction after the end of 12 weeks. And when it is used in combination of ezetimibe, then around 40% fixed dose combination of 180 and 10, a reduction of around 15% of the LDL at the end of 12 weeks has been seen. Again, one more benefit from the bempedoic acid is that some of the statins are known to say the patient are more prone to develop diabetes in the future. the trials have shown that bempedoic acid in diabetic patients can lead to slight reduction in the blood sugar levels.
So as we know,
Bempedoic acid, 4% cases can cause onset diabetes. It can cause also hyperuricemia.
So
So you have to be careful.
it can cause
What they have recorded,
hyperuricemia. It's a known
what they have
side effect.
recorded that despite the maximum dose of statin against a wife, if the LDL has come down normal, you add it. But when LDL has come down, it has not affected the comorbidity and mortality. In the original book which came, I read it. So I thought subsequently these various trials are coming and they're talking very positively for bempedoic acid. I'm surprised because some of the companies say we are sending it out.
See, actually, bempedoic acid, as you rightly mentioned, it's an armamentarium basically for statin intolerance. And statin intolerance is common, although not very common, but it's common. So let us be very clear here that bempedoic acid has some of its own limitations, like as you rightly said, it can cause hyperuricemia, sir. And patients who have a high uric acid, you must be cautious. When a patient is on fluoroquinolones, you must be cautious. Some cases, some reports of tendon ruptures have also been reported. The latest clear outcome trial actually looked at mortality benefit also, and it shows a mortality benefit. So let us understand 2-3 things very clearly. If you reduce the LDL by whatever means, you are going to have a mortality benefit. So any drug, any way, if your LDL is coming down to your goal, which should be at least 55 milligram % in all patients with documented atherosclerotic cardiovascular disease, and maybe up to 30 or 40 in patients who are extreme risk. And Lipid Association of India actually endorses that. I'm also a part of that. And now probably the thought is going in Indian patients maybe to reach up to a level of 15 or 20 LDL might be something which we might be aiming for. And PCSK9 inhibitors do that, but they are very, very expensive drugs. We have used in a couple of our familial hypercholesterolemia patients, patients who are not achieving their LDL goal up to 55 or maybe 40 or 30 as the case may be. But the bottom line is, if you reduce your LDL, lower is the better. Unlike we were discussing about blood pressure, don't go below 120, but for LDL, go as low as possible, as is safe. Yes, if you go very low, some incidences of hemorrhagic stroke or some cataracts or neurocognitive decline, there are, I would say, an issue. But yes, statin intolerant patients, patients who are not achieving their goals despite high dose statins, or patients who sometimes do well on a moderate statin with ezetimibe and bempedoic acid. I am an interventional cardiologist, so we hardly achieve an LDL of 55 with high-dose statins in majority of patients. Some of them may be hyper-responders, Indians are. But we have to use a combination. And I think the advantage of bempedoic acid coming into the market is our usage of ezetimibe has increased, which was low. So now we are more and more into using multiple drug combinations and trying to achieve the LDL level of around 55 or so. I have one patient who actually I've been treating for last 2 to 3 years with an LDL of 170, 180, strong family history of CAD, doesn't tolerate any statin. I have tried pitavastatin, I've tried atorvastatin, I've tried rosuvastatin, and now ultimately when this drug came, I tried ezetimibe alone, but that doesn't produce a phenomenal LDL decrease. Now she's on a combination of bempedoic acid and ezetimibe. She doesn't want to take PCSK9 inhibitors because of cost. So there are areas in which bempedoic acid has a role. Yes, it's not as robust LDL lowering as statins. Statins still and will always remain #1 drugs. The kind of data we have, the kind of intravascular studies and the OCT studies we have on the coronary atheroma, that these drugs actually regress the plaque. So that kind of a data with bempedoic acid and ezetimibe probably is not there. But yes, these all drugs are partners and they have their individual roles in different scenarios, and especially in high-risk patients like Indians who develop coronary artery disease prematurely at a lower level of LDL. And sometimes you may have a patient who is coming with a multiple coronary artery disease or stroke events and LDL is around 40, 50. What to do with these kind of patients? We don't know. So maybe targeting triglycerides and other things. So it's a matter of discussion. We can keep on discussing on.
Such a scenario when you are finding LDL very high. Now, as such, he has got hyperuricemia. Bempedoic acid is going to increase it. Diabetic control, like if you remember, the niacin came and went out because of the side effects. It also, the control of the diabetes had go haywire and patient went to gout, that happened like that. Same situation, I'm only worried that this has gone 4% only, hyperuricemia and new onset diabetes. What will you do in those situations?
Yeah, so as of now, if there's a severe hyperuricemia, you don't start this drug. If there's a mild or moderate hyperuricemia, you try to control the uric acid and then maybe give the benefit of this drug. You have to have a cautious watch on uric acid. That is very important.
And then there is another important aspect. We all know that there is concept of residual risk with whatsoever available therapy we have till now, aspirin and statin, which was the established therapy. Despite achieving our goals with them, trying to achieve our goals with them, we still have a residual risk of 15 to 20% cardiovascular mortality. We cannot reduce it as low as in a normal person. We need to address that also.
We can do that, sir, but actually uric acid and hyperuricemia is more of a part of metabolic syndrome. You reduce the obesity, you reduce the, you take care of the diet, and then once you are able to bring the uric acid to normal, you will be more comfortable in starting this drug. With already a uric acid high, starting this drug may be a problem. So that is one limitation of this drug. Yeah. So sometimes your patient may have, suppose, a heart failure also, hypertension also. You can use losartan, which reduces the uric acid. You can use SGLT2 inhibitors, which again reduces the uric acid. So that kind of a pharmacologic, I would say, jugglery can be done. But yes, one must be very cautious that if there's a high uric acid or the patient is on fluoroquinolones, bempedoic acid may not be a choice.
Thank you, sir. My next question will be to Dr. Dheeraj, sir. Sir, we have been talking about the LDL targets. Is there any effect of lowering the triglyceride levels in a patient with diabetes?
I think that is a very relevant question. And speaking about diabetes, diabetes is probably the mother of so many disorders and diseases. And it's a disease which actually bring all kind of physicians on the common platform. So coming to the diabetic dyslipidemia, patients with diabetes have this special kind of a dyslipidemia in which they will have a low HDL level, they will have a high triglyceride levels, and their LDL levels may not be very high, but the kind of LDL they have is quite classical. It is a small dense LDL, and this kind of LDL is very atherogenic. So per se, you have to evaluate the whole lipid profile of the patients who come to you with diabetes. And as they say, when you treat diabetes, you just not treat the sugars, you treat the patient as a whole. You treat all his risk factors. So I think a lipid profile is a must in the first visit for all these patients. And besides the LDL target, which we have been talking about, there is an entity which we call as the non-HDL levels, and these non-HDL targets are to be achieved. So when you talk about the triglyceride levels per se, you can actually classify the triglyceridemia into severe category. They say then when the triglyceride levels are more than 500, it is a severe triglyceridemia. And between 150 to 499, we call it as a mild to moderate elevation. So when you find the TG levels are very high, you have to look upon the basic things. First, you should rule out the presence of other disorders, like if the patient is hypothyroid, that will add to the triglyceride levels. You first treat the glycemic status first, and you should look for drugs which can cause increased triglyceride levels. So after ruling out all these possibilities, and with the maximal dose of statins, if the patient is still having hypertriglyceridemia and it is a severe triglyceridemia, you should definitely treat it. And I think my cutoff in my clinical practice is anybody who has TGs more than 400, I usually add on drugs to reduce their triglyceride levels.
So nowadays, all the anti-diabetic drugs are being evaluated for their cardiovascular outcomes. So what is the...
diabetes, we control diabetes. Now you have got two drugs with you. Indication for saroglitazone is if it is more than 300. Some say even more than 200 you add. But the caveat is the LDL should be normal. Now LDL is also high. If it is high, that's no problem. In that scenario, pioglitazone is the one drug which you can use for this case along with EVO, vitamin E. That will help. But otherwise, triglyceride as such has no worry. Worry the pancreatitis is very.
And I think one more thing which is very important, especially when we use fibrates, in patients who have already pre-existing gallstone disease, the fibrates can actually increase the gallstone and they can actually increase the incidence of pancreatitis.
And one more important point here is triglycerides are very, very important, but the first and foremost aim is to have a dietary control to reduce triglycerides. So carbohydrate reduction, that is number one. Patients might be very much worried if the triglycerides are more than 500, the issue is not coronary artery disease, the issue is pancreatitis. So that needs to be treated with aggressive therapy, maybe saroglitazar or fibrates. But if it is a moderate sort of hypertriglyceridemia, then strict diet control, I think, is the most important. And second thing, and no, yes, absolutely, sir. And the other causes like alcohol, which is very, very practical. One must always ask, are you alcoholic? And in 50-70% of the patients will tell you they take alcohol every day. So control of diabetes, alcohol, as Dr. Dheeraj said, the drugs which can increase triglycerides. But it's also very, very important to understand that Indians many times will have more of high triglyceride levels and less of LDL elevation, and we are more prone to coronary artery disease. So there are certain drugs like eicosapentail ether, which have now come up, some omega-3 fatty acids, which have now shown some mortality benefit also in reducing triglycerides. So although triglycerides have been a neglected cousin as far as coronary artery disease is concerned, nevertheless they are very important, but the evidence for triglyceride reduction translating into improved cardiovascular outcomes is much, much less when compared to the evidence of LDL reduction in improving cardiovascular outcomes. So triglycerides still is an area of great research. There are certain drugs, I'm forgetting the name, which is monoclonal antibody, which is actually being addressed to looking at the severe hypertriglyceridemia levels. Saroglitazar, an extremely good drug, will never come to the fore because it's not an American drug. So it will never achieve an FDA approval. But we have seen in our practice the kind of triglyceride reduction this drug does is much better than fenofibrate. And combining statins and fenofibrates increases a lot of muscle toxicity and patients do not tolerate it. So probably my choice usually is a combination of statin along with saroglitazar, and that takes care of the fatty liver and other things also. But diet control, absolute alcohol restriction, all these things become very, very important as far as triglyceride reduction is concerned.
Thank you, sir. Nowadays, all the newer drugs are being evaluated for cardiovascular outcomes. So my final question will be to Dr. Venkat, sir. Sir, SGLT2 inhibitors and GLP-1 analogs both have found a good cardiovascular outcome. So which one should be preferred and what should be the patient demography for that?
It's a very interesting question. The problem is SGLT2 is also a recommended drug with good CVOT outcome, and GLP-1 analogs, receptor analogs have also been of the same kind with very good CVOT outcomes. Now, the only difference between the two is a very fine line. GLP-1, the benefit is seen for all MACE3, that is all-cause mortality, basically cardiac-related mortality and stroke-related mortality. Whereas if you go for SGLT2 inhibitor, it is mainly benefited from the cardiac mortality like heart failure and MI. So GLP-1 RA is more beneficial when we want to go for a overall protective CVOT benefits. But yes, diabetes control, both of them are nearly equal. Weight loss, over a long period of time, GLP-1 better compared to SGLT2. Because CVOT benefit is not just basically about mortality benefit. It's about all the other things like sugar control, weight loss, and everything else. So if you ask me, there is not much difference between the two drugs. They work synergistically in this manner. But patients who are at a higher risk of peripheral vascular disease, there is a little red herring or a little warning about using of SGLT2 in these cases, because there has been some incidents with canagliflozin where amputation risk had increased, but the US FDA has removed that warning in 2020. But then still they say if there is a patient who has revascularization has been done, a person who has significant blockade of vascular vessels in the body, SGLT2 inhibitors should be used with extreme caution. So both drugs are equally efficacious. It is your choice which you want to use it. You can use it synergistically also if you want to use it. But MACE3 benefit with GLP receptor analog is more compared to SGLT2, which is more beneficial for heart failure and cardiac benefit. That is what the data is saying, but then there is no specific head-on trial between the two which is very clear on this matter.
Thank you, sir. I would like to thank all the panelists for a wonderful discussion. We can now move on to our next session.